السلام عليكم ورحمة الله. يعطيكم العافية. Hello everyone. I'm very sorry because I wasn't able to finish these remaining slides from the cholinergic antagonist lecture, so that's why I would like to record them and send them over to you, inshallah. We did stop at this stage where we mentioned that the anti-nicotinic drugs, the other name for them is the neuromuscular junction blockers. And we mentioned that the idea came from studying a certain poison named curare that certain South American tribes used to derive from certain trees and coat their hunting arrows with it to facilitate hunting. And then the active substance as tubocurarine was discovered in medicine in 1940, and it was used to cause paralysis of skeletal muscle. So why we need, as I discussed in the lecture, why we need to paralyze a certain group of muscles, or because it's generalized, actually all the skeletal muscles, is because sometimes there are certain indications in the operating theater that would make the operation or the surgery much easier if the patient is paralyzed. So these agents basically are structural analogs of acetylcholine. So they look like acetylcholine in their structure, and accordingly they can bind with the nicotinic receptors at the motor end plate. So basically, when they block the cholinergic transmission, then they are going to produce the paralysis. However, when we classify them, we have two types. We have the as simple as just occupying the receptor and not allowing acetylcholine to reach. That is going to produce what we call non-depolarizing neuromuscular blockers, or they work like antagonists to the nicotinic receptor. Anything that occupies the receptor and does not allow the active, the agonist to reach, then this is going to be defined as antagonist, and it will not cause depolarization. It will interfere with the action potential. So that's why this is group A. Group B actually are classified as agonists because they will bind with the receptor and cause initial depolarization before they cause the muscle paralysis. Okay, so why we need to produce muscle paralysis is because sometimes muscle relaxation in orthopedic surgery is wanted. If an orthopedic surgeon would like to change hip joint or a knee joint, then you need the whole muscles to be sort of lax and very without having any tone inside them, and that will facilitate the mobility and mobilization of the whole patient, actually, not even the joint. So that will make the operation very easy. In addition, the second indication is if under general anesthesia, you need definitely to connect the patient to an endotracheal tube. You need to insert an endotracheal tube with the help of the laryngoscope here. This is the endotracheal tube, and then you will connect that with an ambu bag until your ventilator is ready to be connected, and the patient will be under artificial ventilation as long as the surgery is going on. So in order to insert this endotracheal tube inside the through the larynx to the to the trachea, then we need the neck to be hyperextended. So the positioning of the head itself to facilitate the intubation needs muscle relaxation. It's actually paralysis, not even relaxation. So, but we call them relaxants, neuromuscular relaxants, but they are actually paralyzing agents. Now, this table shows you the two types that I've just mentioned to you. Here you have the non-depolarizing neuromuscular blockers, cisatracurium and pancuronium and rocuronium, and there are others. For the depolarizing, we have only one, which is the succinylcholine or succinylcholine. The kinetics difference between the two is that this one, succinylcholine, very short acting, so it needs to be as intravenous infusion as long as the surgery is going on. Okay, why? Because it's very short acting, acts within minutes, and it results from the reason why it only acts for a few minutes is because there will be rapid redistribution and hydrolysis by a certain enzyme called plasma cholinesterase, or the other name for it, because it's different from acetylcholinesterase that we find in synaptic cleft. This is something in the bloodstream, so we call it plasma cholinesterase or pseudocholinesterase. For the other group, actually, they are even longer acting. They can act for 1 hour or more. Accordingly, we can give them as bolus if you wish, or we can, again, combine bolus with infusion. Say, for example, the surgery is going to be like for 3 hours. Then we can start with a bolus dose and then start the infusion as long as you're not entirely sure when you're going to finish on the surgery. So you can give bolus and you can give infusion as well. And the action is terminated by, again, there are going to be redistribution will happen and hydrolysis reaction plus hepatic metabolism. So there is more than one way of terminating the action. The mechanism of action, as I told you, for the non-depolarizing, they're going to prevent binding acetylcholine to nicotinic receptor because they just occupy the receptor as antagonists. So they will prevent depolarization and inhibit muscle contraction. So these are actually competitive antagonists. And the order of paralysis, the first actually muscles that the anesthesiologist is going to notice that they are becoming paralyzed is the face, eyes, fingers, it goes with that order. And the last muscle is diaphragm, okay? And the reversal, once they are stopped, actually the diaphragm will start first before and then intercostal muscle. So the reverse is going to be, the recovery is going to be in the other reverse direction. Now, when we see a 6-phenylcholine, on the other hand, the mechanism of action is that I told you that it's something, you remember the depolarizing neuromuscular blockade that I told you in case of nerve agent intoxication. This is actually similar mechanism. Here we have a structure that looks like acetylcholine, but it's not going to be metabolized by acetylcholinesterase. So it's going to last longer, for minutes. So it acts like acetylcholine, and it will bind with the nicotinic receptor and cause depolarization initially. And this depolarization, it's going to be persistent depolarization. And this is going to be like phase 1. And that's why they call it phase 1 block, because it will cause this depolarization and the muscle will be stuck in that phase. And it's during that phase that you might even see, if somebody is operating and looking at the, arms and legs of the patient, you can see by your eyes the muscle fasciculations that is happening as a response for this persistent depolarization. However, there will be no depolarization that follows, as normally when acetylcholine is degraded within 5 seconds. Okay, so there will be no depolarization, and that will lead this, because this phase 1 block is going to be followed by phase 2, which is the desensitization phase. Desensitization phase, it means that the muscle will lose the ability to respond to acetylcholine after what happened in phase 1. And if it loses this ability, that means it will undergo complete paralysis. Okay, so that's actually the mechanism of action for this drug. Now, the adverse effect for the non-depolarizing neuromuscular, because they do not have, a big list like 6-phenylcholine, okay? The most important is that they might, you need to watch out for certain drug interactions. Cholinesterase inhibitors can overcome their effect. This is one of the uses of, for example, mustigmin or pergistigmin. If somebody, say for example, because these are actually working for an hour or so, say for example that we have given a bolus or at least an infusion, and there is a certain infused, or we have given a certain dose from that muscle relaxant into that patient. And that patient, the anesthesiologists are discussing with the surgeons, and the surgeons is telling you, I'm finishing within like 10 minutes from now. And the effect of the muscle relaxant is going to last for longer period of time. So how can the anesthesiologist reverse the effect of these medicines? Is by actually giving mustigmin and pergistigmin, because they're going, as I told you, they are competitive antagonists. So whenever you give something that's going to build acetylcholine, then acetylcholine with the high concentration, it's going to overcome the block by displacing them and accessing its own receptor and cause muscle contractility, and the surgery can be terminated. Patient can, gain their consciousness, because you need to make sure that the skeletal muscles, especially the diaphragm and intercostal muscles, are working before you can extubate that patient. The other side drug interaction is aminoglycosides. Say, for example, that patient, before he was sent for surgery, he had a UTI or something, and he needed aminoglycosides, which is very commonly used to eradicate gram-negative bacilli infection. This is a group of antibiotics that, by themselves, they inhibit acetylcholine release from cholinergic nerves. They're not going to cause actually much of problem in the patient, but if the patient was being treated with them, and now he's getting uh, during the surgery, he's getting neuromuscular junction blockers, then you might see an exaggerated or the synergistic effect with the effect of neuromuscular blockers. So that's why, على فكرة, usual anesthesiologists, they take a detailed history from the patient before they send them to OR, okay? And they review their medications, they take, lots of information. Family history is very important for succinylcholine as well, because they need actually to make sure and prepare that the anesthesia itself is safe for the patient. Look at succinylcholine. One of the most important side effects for it is a condition called malignant hyperthermia. What does that mean? It means actually this is an inherited condition, and it is inherited as autosomal dominant, unfortunately. And this is a condition where, in the normal circumstances, the patient will not have any problem at all. It's only when they are sent to OR and they get exposed to a certain inhaled anesthetic agents, okay, like the halothane, for example, or get exposed to succinylcholine. Then there is something, these are considered as triggers. And then what will happen is that the muscles will undergo a state of persistent contractility. And the persistent contractility, the muscle will need a continuous supply of oxygen and to generate energy. But the problem is that there is no adequate supply for this sustained sort of contractility that happens. So there will be a state of hypermetabolism or hypercatabolism, because the muscle itself might need an anaerobic metabolism with generation of lactic acid and metabolic acidosis, and there will be muscle rigidity and there will be metabolic acidosis and stimulation of the sympathetic nervous system as a whole. And because of this hypermetabolism generate heat, and definitely the body temperature will be increased. And to the worst circumstances, there will be rhabdomyolysis, DIC, some cardiac arrhythmia, and death. This is a condition why that happens with the exposure to these triggers, is because these individuals, what we know so far is that they have an abnormality in the ryanodine receptor, which is a calcium channel receptor on sarcoplasmic reticulum of the skeletal muscles. So the abnormality in that receptor, there is a problem with the calcium transport across that receptor. Okay, so what it seems like it is that once some calcium entry happens inside the skeletal muscles, it stimulates actually release from sarcoplasmic reticulum. But what happens is that there's abnormality in that receptor, and it opens and never closes again. So it's going to release a tremendous amount of calcium to the cytoplasm of the skeletal muscle cells, and this is what's going to cause this sustained contractility. That's what we know about this condition. Okay, how is it going to be treated? When this condition was discovered in 1960, the mortality rate was about like 80%. Most of those who get it, they will die. But with the development or with discovery of dantrolene, that's the only medicine, that the only one that can help in this condition. Dantrolene is going to close the ryanodine receptors and stop further release of calcium from the sarcoplasmic reticulum. It's given intravenously. So dantrolene actually is the drug that can help to eradicate this problem, to prevent and to treat this condition. And mortality nowadays is less than 5%, fortunately. And this is actually a kind of a very common scenario where anesthesiologists need to train their residents how to deal with malignant hyperthermia in case it happens, because you do not know unless you put that patient under the condition where he gets exposed to these triggers, and then he will have it. What actually helps is the good history. They can history taking because it is an autosomal dominant condition. So there must be somebody in the family who had a general surgery and got exposed and had some complication. You can act as a patient. The patient can report to you, for example, that my mom had appendectomy and then something weird happened, and so that kind of history will give the anesthesiologist an idea that this patient might have such a problem. The other side effect is that there are some individuals, and this is rare, where they are deficient of pseudocholinesterase. So accordingly, the half-life of succinylcholine is going to be longer, and apnea is going to be, that's the thing actually that you're waiting for, because you need the patient after, during recovery to breathe by themselves. So that is going to be prolonged muscle paralysis with succinylcholine dose. Hyperkalemia, it happens because of this depolarization that happens, the persistent depolarization that happens, then the muscle will release the potassium inside it to the bloodstream, and you might see some hyperkalemia after as a complication of succinylcholine use. The post-operative pain, this is actually the way that the patient will feel the fasciculations. You as a physician, you will see the fasciculations by yourself, but this is something that the patient after the surgery will tell you that I have muscle pain, and this is because of the fasciculations that happen. Now in this table, I just want to show you very quickly. You do not need to learn exactly the half-life, but do you see here succinylcholine? The onset of action is 1 minute, and some reports even they say 30 seconds. And the duration of action is 8 minutes. So it's very short acting. So that actually makes the surgery very sort of, the infusion is going on, and whenever we want to finish the surgery, then the patient can, breathe by themselves after we finish from this muscle paralysis. So that's why anesthesiologists still, it's an old drug, but it's still being used because it's very easy to titrate and very easy to get rid of the muscle paralysis if we want to terminate if we want to stop the surgery itself. The other ones are even in duration of action is longer, so you need to be prepared for longer period of action. Succinylcholine is very popular drug, and to be honest with you, it's again very popular, not even in OR, it's popular for assassination. So sometimes, especially if the killer is a healthcare professional في الواقع, right? Because they might take a big dose of succinylcholine and administer that to somebody, and even during sleep, for example, by intramuscular injection, and then it will be quickly, do you see the onset of action is going to be very quick, within minutes the muscle paralysis will happen, and it's 8 minutes is enough to kill somebody. If somebody cannot actually breathe for 8 minutes, then they will die. And it is very why it is good, because there will be no metabolites. It's very, very quickly metabolized and redistributed from the bloodstream. So it's a good agent, unfortunately, that is used for assassination as well as general surgeries. If you have any questions, please, you can email me, and inshallah, I will send you the answer for it. Good luck.